sleeping mostly. Okay, thank you very much for giving me the opportunity to stand here and give a presentation. So I was told to give a presentation. So I was like, I'm really into this end of life care. So like just now, Nazmin Appa gave her presentation on right to health regarding HIV/AIDS. So my topic will be right to death. That means peaceful death. That is a good death. That is, even though we are all here living, but someday everybody of us will be leaving this world. Will be leaving this world. So it's my title of my presentation is End of Life Care. That is, we should begin to think about what is really end of life care. So, like Daryl said, and we all know that we have moved from Millennium Development Goal to Sustainable Development Goal. And to achieve this goal, we are now having a policy around the world that is universal health coverage. So on that perspective, universal health coverage, that is, they are trying, this is a healthcare system that is going to be delivering the, we know like, for the public health, that is giving the preventive, promotive, curative and rehabilitative health care. But now this rehabilitative health care, it is gone into this palliative care. That like Appa just now said, HIV patients, like what is their, because ultimately there will be a time they are ending their life. So how to tackle this kind of patients? So end of life care patients are those patients that are having chronic illness and they are just suffering from they are just ending towards death. So how to tackle these kind of patients? So on 14th October, over 150 events around the world, I mean in 45 countries around the world, celebrated the World Hospice and Palliative Care Day and Voices for Hospices 2017. And the theme was universal health coverage and palliative care. That is, don't leave those suffering behind. Okay? So around 40 to 61 million people need palliative care annually, and including 20 to 25.5 million at the end of life. So you see a huge amount of persons are near to death, even though we are now sitting here, you know. So they are suffering, but how are we going to tackle these kinds of population? So with about 80% of those, sorry to say, living in low and middle income countries, so that means we are among that countries. Yet the World Health Organization estimates that only 14% of this need is being met at the end of life and less than 10% overall. So you see the coverage is very less and we really need to think about this matter. So in 42% of the world's countries, there is zero availability of palliative care, and in only 20 countries is palliative care well integrated into the healthcare system. So what about our country? So end of life care in Bangladesh picture, there is only 5 to 6 organizations are providing palliative care in Bangladesh, and ASHIK, that is palliative care unit, is the first such unit in Bangladesh for the children. That is, they are taking care of the children who are suffering from cancer children. A total of 30 to 40 inpatient beds are available for palliative patients, which are government and private resources combined, such as BSMMA, that is PG, like we say, Ahmed Medical Center, Delta Medical Center, Bangladesh Medical College Hospital. So you see, it's a very small amount of hospitals and private and government providing this end-of-life care treatment, care. So what is really end-of-life care? So end-of-life care is one of the core components of palliative care. Palliative care makes you as comfortable as possible by managing your pain and other distressing symptoms. So HIV is included in that. So, and is the central to provision of good general care. So the end is that, well, you're dying, so just die. It's not that. That should not be the aim. Because, like us now, we are having a dignitary life, But when we are approaching to death, that death has to be a peaceful and good death with dignity. That is the aim of this end-of-life care, and that includes in the palliative care. So ensuring that people receive a good care at the end of life has been seen as a high priority during the past decade. So it's a matter of thinking. Maybe has not been yet, because that is why some only the organization or government level organization are giving this care. But in the outside world of, outside of Bangladesh, this care is really based into a very good palliative care centers. So Bangladesh remains far behind what is needed to minimize the pain and sufferings of patients when they know their death is imminent. So a growing body of evidence demonstrates the importance of end-of-life care in ICU. So we know what happens in the ICU. If you know your beloved persons, or some of you have maybe, who has gone into the ICU or have seen the patients in the ICU, how much suffering they are. Even for the patient, he or herself is suffering, but the families are also suffering, For many patients admitted to the intensive care unit, preferences for end-of-life care are unknown. Clinicians and substitute decision makers are required to make decisions about the goals of care on their behalf, because the patients might be, having the life support, so they won't be able to tell that what would their health care, what would be their treatment. So on their behalf, the carer, the person who are taking care of them, they are taking the decisions. So it's a dilemma kind of. So end-of-life care in ICUs often inadequate because of the factors such as lack of communication between patients and the healthcare providers. So patients and the healthcare providers, the doctors and nurses, they have the lack of communication. So they don't have this how the treatment should be provided. And then the lack of patient and the family-centered care. End-of-life care, it's not about only the patient and the healthcare provider, but also the doctors and the families whose patients are admitted. So it's totally a team, like the family, the patient, and the healthcare provider. And then the third one is the lack of emotional and psychosocial support. Here, the patient is lying on the bed, but the support and the psychosocial support for the person, the bereavement families, the person who are handling, the family member, we really don't have those. The patients are dying, die, finish, they go. But the families who are suffering, they really need this support. That is not here, at least in our country. So what end-of-life care really involves? Support for the people who are in the last months or years of their life. Number 2, life as well as possible until you die, and to die with dignity. That is the support you need. That is, you die, but we die with dignity. Not like, having sympathy, he's dying. People, just don't care. That is what is happening with the patients who is dying. Providing care should ask you about your wishes and preferences, and take those into account as they work with you and to plan your care. That means when you are a patient, what happens is that the family members, they don't even sometimes, they don't even the healthcare provider, they ask the families, not the patient, what really he or she wants for the care. This is an ethical part, that wish of the patient, what really the patient wants. Some patients may be in the life support, that means the family can take care of them. But the patient who are ending their life, but they are still conscious, their wishes really counts. That is an ethical issue. Then support family, carers and other people who are important, because they are also going through a process of bereavement, that is their family. They are psychologically upset. So there should be a corner, there should be a place where they can get a psychosocial support. And express wishes about where would like to receive the care and where want to die. So end-of-life care is not something that is only going to end in the hospital. Even that care can be provided at home also. You see, end-of-life care at home or in care homes hospices and or hospitals, depending on the needs and preferences, and entitled to high quality care wherever they are being cared for. 10 most important needs of the families and critically ill dying patients. So let's see what are the 10 most important things that the family and the patient really needs. To be with the person. Yes, when sometimes, like nowadays, what happens is that we have like beautiful hospitals like Square, and then the Apollo, and then there is another one is the United Hospitals. When they are in the HU, you can see the patient, but when they are in the ICU, that means they are like end of life care, but they are not being really given the chance to visit them. They have a scheduled time to visit, and you can only watch them in the monitor. And this is a time that a patient needs the family. They need the care of the hospital, but at the same time they want to be near the family, but it's not there. That is not the way to give end of life care, the support. So you have, if the person is with the family, the treatments, the prognosis of the disease or complications, it lessens much more, so to be with the person. And number 2, to be helpful to the dying person. If you are with them, you talk to them, they feel good about it. To be informed of the dying person's changing condition. Sometimes like I have to share my story now at this moment. Like I was about near to death 1 year back. So even I'm a doctor, I was asking my doctor, well doctor, I'm suffering, what can be my diagnosis? The doctor was screaming in the room like, am I obliged to answer you? Do you know, is it so easy to tell what is your diagnosis? Was that a way to answer a patient? That means I am a patient at that time. I needed the answer. So to be informed the dying person's condition. So every family member, all the doctors are accountable. They have to know what's going on inside that ICU. What's really happening, time to time, hour to hour, even minutes to minutes if the patient really wants to know, the family member wants to know. Even if the patient is conscious, if they want to know what is going on, definitely they are accountable to answer that. But it's not happening in the real picture. To understand what is being done to the patient and why. So you see, I just told you my story, what happened. Why? I didn't even ask why. I said, what was my diagnosis? And that was all. To be assured of the patient's comfort, so whether the patient is at least in the comfortable level. To be comforted, to ventilate emotions, for the patient and the family too. There should be a corner where they need to ventilate because their beloved persons are in the bed. And also the patient herself having all the thoughts, what is going to happen after his or her death. So needs to ventilate the emotion. There should be a counseling section. Is there anywhere in our country? None. And to be assured that their decisions were right. Okay? To find meaning in the dying of their loved one, to be fed, hydrated, and rested. When does the end of life really begin? End of life care should begin when you need it and may last maybe a few days, even for months or even years. You don't know when you're dying sometimes. So it can last for a few days, months, or years. People in lots of different situations can benefit from end of life care. Some of them may be expected to die within next few days or hours or days. Sometimes the doctors say, well, the patient is in a critical situation. I think the patient will be surviving for a few hours or few days or even weeks, Or maybe, the doctor might be proved wrong sometimes. He doesn't know, but, seeing all the medical conditions and everything, they can say that. So that is the time when the end of life care begins. People are considered to be approaching at the end of life when they are likely to die within the next 12 months, although this isn't always possible to predict. So this includes people whose death is imminent, that is, seeing the medical condition, as well as people who have an advanced incurable disease, illness as cancer, dementia or motor neuron disease, but also definitely the HIV cases, okay? And are generally frail and have coexisting conditions that mean they are expected to die within 12 months. Have existing conditions if they are at risk of dying from a sudden crisis in their conditions. Have a life-threatening acute condition caused by a sudden catastrophic event such as an accident or stroke. So now let's see who can really provide this end-of-life care. Is it only the healthcare provider, that is the doctors and nurses, or the hospital team? Different health and social care professionals may be involved in your end-of-life care depending on the needs. For example, hospital doctors, nurses, general practitioners, community nurses, hospice staff, counselors. So see, counselors are also involved in this. May all be involved, as well as social care staff, chaplains. I mean, it's not chaplains. I mean, in our country, even the imam, the religion leaders, So physiotherapists, definitely so, occupational therapists and complementary therapists. If being cared for home, sometimes, end of life care, we can bring the patient, like my aunt, when she was conscious enough, she said, if anything ever happens to me, like stroke or any kinds of thing that is lingering my death, sudden death is not occurring, please do not take me to the hospital. Just manage me at home. And that was, we really granted her wish. My sisters, they took care of her at home. The physiotherapist came, the religious leaders like the one imam, he used to come and counsel everybody, So if being cared for at home or in care home, general practitioners has overall responsibility for the care. So one doctor was always coming to check on her, okay? And nurses usually visit at home, and family and friends may closely involve in caring too. So at the last moment, if the family has an opportunity to take care of their loved ones at home, the bereavement process is more better. Because when somebody is dying in the hospital and you just hear the person is no more, the process of bereavement is really unbearable. You cannot take that death suddenly. You got it? Like in Indonesia, there is a ethnic group. As far as I know, I forgot. I think it's named Trozans or something like that. When somebody, their loved one dies, they don't just bury them. They keep them. Even there is a case of keeping the dead body at home for 12 years. So the children, they themselves, they feel like their elders or their loved ones are still around them. Every hour they give some food and everything. So you see their bereavement, and then ultimately when they bury it, they don't bury even. They have a room, they just put it there. Once a year they take out the body and then they just pray and everything, then they put it back. And then ultimately when they feel like surrendering, okay, it's enough now, we can let the person go, then only ultimate bury is there. So you see, sudden. So end of life care at home, if you can give, this is a better opportunity for letting the loved ones to go from us, Okay. So what it means in practice? The most effective end-of-life care is provided when there is a skillful communication with patients and families about realistic goals of care and attention to understanding the patients and families' concern, as well as a competent symptomatic management. So end-of-life care is all about the symptomatic management. In order to achieve the goals which are important to patients and families and to provide good end-of-life care, it is essential to identify that a patient is imminent to dying. It is sometimes difficult to identify when a person is close to the terminal phase with a prognosis of days to weeks, but where this is possible, this knowledge may be of great value to patients so that they can reorient their priorities. So in this case, if sometimes when the doctors or healthcare provider says, that maybe the patient is going to die a few days or few hours or few months after, if the patient also knows about it, or the patient's The families knows about it, so they can reorient it, which priority, sometimes, they can reorient their priorities, what they should do and what should not do, which are the things in their life are priority, you understand? So principles of good end of life care. The factors that are most important to patients and families at the end of life are pain and symptom management. The chronic illness, they really suffer from the pain, so we really want that the pain and the symptomatic management. Preparation for the end of life. Relationship between the patient, family members and the healthcare provider. It's a teamwork, and feeling a sense of control. Like you feel if you have really a good quality of end of life care for the patient, the family, the healthcare provider and the patient, they feel like it's in their control, that all the things, Finding a spiritual and emotional sense of completion. And affirming the patient as a unique and worthy person. That's why I say that when you are approaching a death, that means you die that means you want a dignitary death. That is, die with a dignity. So you have a sense of completion and you feel like you are a worthy person. Strengthening relationship with loved ones and not being alone. So in the hospitals, the quality standards of end of life care, there are 4 aspects of end of life care. That is, the hospital, they can do is what? The hospital has a system in place to ensure that the end of life care is central to the mission of the hospital and is organized around the needs of the patient. The staff, what the staff can do is that staff are supported through the training and development to ensure they are competent and compassionate in carrying out their roles in the end of life care. And regarding the patient, each patient receives high quality of end of life care that is appropriate to his or her needs and wishes. And the family, that's the one. Family members are provided with compassionate support and subject to patient's consent and given information before, during and after the patient's death. So, even though it's not, my presentation is divided into 2 parts. I'm talked about this end of life care. Then I'll be telling you about my studies, what I did in the masters. Okay, so that's why this is the conclusion. So Bangladesh faces huge unmet needs of patients with life-limiting illness, where it is about achieving the highest quality of life and promoting comfort and self-respect of patients with not only incurable but also life-limiting disease. End of life care promotion has been strengthened by announcing that allocation of end of life care is a human right. It's just like right to health, I said before, it's a right to death, that is die in a peaceful death and good death. To overcome the barriers to successful implementation of end of life care, we need continued efforts, and it is our not only ethical but a moral obligation to do whatever we can. So I'll finish my first part of the presentation by founders of modern hospice movement, that is James Saunders, stated that you matter to the last moment of your life and will do that we can not only to help you die peacefully but to live until you die. So until every moment is important of your life. Every moment, Jio. You understand? Every moment, even you are dying. Sorry, there is Jio should living. Okay, that is a Hindi word. Okay, so you're dying, but every moment should be what?
Joyful.
Joyful, Pranavamtu. Right. Thank you so much. So the changes being sought are in awareness, attitude, skills, practice, and organizations of this end of life care. Next. So when I did this masters in AUSN, my topic was regarding this end of life care in the adult intensive care unit, attitude and practices of critical care physician and nurses. Well, this was my title, and I wanted to show you the results only. Okay. So methodology, that is, I took the patient, 45 patients were, 45 doctors and nurses. Among them 23 were doctors and 22 were nurses. And I did, the IC was an NICBD, National Heart Foundation, and Holy Family Hospital, okay. So sampling technique was like purposely selected. No? face-to-face interview with the doctors and nurses, and I already said that. Okay, go on. Males were more, the doctors were more, 51%, and female were 49%, and more than half were the doctors having bachelor degree. That means just MBBS. That means they didn't have that much of training, or they just interned. They were serving the ICU, And the nurses, they had the diploma. And more than half, that's 56% of the doctors, and nearly half, 44% of the nurses had formal education or training in critical care. Among the doctors, 37% had 1 to 5 years, and 62% of nurses had 6 to 10 years of ICU experience. So you see, the nurses were more about working in the ICU rather than the doctor. Doctors were like they were switching the other departments, not working in the ICU. So their kind of concept and their psychological support, I felt like the doctors were not that much of connected to the patient. That is what I felt. That's my perception. And you can see that by the time the nurses worked in the ICU, only 1 to 5 years the doctors were working, had an experience in the ICU, and the nurses having 10 years. It's a lot, So overall, 80% reported that they wanted to be involved in the decision making of end-of-life care, and 76% were satisfied with the decision making in the end-of-life care. Mostly, like 71% respondents said that their ability was sufficient to make decisions about end-of-life treatment. Two-thirds, that is 69%, did not think decisions for end-of-life care were usually taken quickly. The end-of-life care, that means they said that they were involved in with the family. They discussed with the family how the treatment should be going on. More than half thought that do not resuscitate order should be present. So in our country, the DNR, that is do not resuscitate, that order it's an advanced directive. That is, the patient sometimes says, but this is not in our culture. Like I said, my aunt already said that whenever happens to me, do not take me to the hospital or try to resuscitate me. If I go, just let me go. So but the patient, the doctors and nurses, their thought was that do not resuscitate order should be present. That was their perspective. Like feeling like when somebody is dying, they should be let die, because letting them to die, because the pain they can feel, like putting the life support and then the medication, the injections and everything. They were from human, this was totally their perception, their understanding. But because they were the healthcare provider, they had to. The patient is dying, they will put whatever the things, the drugs they needed to do, they will be doing. But as a human perspective, they were feeling, no, this should be stopped. The DNR should be there. Somebody is dying, let them die. Do not put them into more pressure of living with such painful death. Nearly half agreed that withholding or withdrawing the life support is unethical, and 56% disagreed that withholding and withdrawing are ethically the same. 60% thought financial costs to society are important factor in influencing decision on the extent of life support therapy to provide to a patient. Yeah, definitely. The ICU really. If anybody is admitted in the ICU, they know that how much it is cost every day, the financial cost. So it's an issue that whether the end of life care, how much time they should be encouraging to stay in the ICU. It's a very tough matter. Most, that is 87% let family attend the meetings with the medical team. The doctors really talk with the family when the end-of-life care things are going on. Moreover, most 80% respondents fully inform the family about all aspects of the plan of care of the patient. So sorry to say, I shared my story that as a doctor, I asked my doctor what was happening. I was really screamed. The doctor screamed at me, but at least fortunate enough those people are, because 80% say they really talk to the family. But maybe I was asking them questions that was their positive. Yeah, we talk to the family very nicely, and in every aspect, whatever their questions are, we answer. But real picture, I don't know. So research must be done more, So more than half permitted the family to visit outside the regular visiting hours. I think here we have some observation, like 56% they say that regular visiting hours before and after they let the patient to be inside the ICU. Do you think it's correct? Though they said, I don't know, I have to bring out the picture because they said it, but I think inner depth research should have been done, because true picture is not there. Regular visiting hour after that, it's really tough. Without giving this, you cannot enter, isn't it? We have to bribe the person. Half asked the family how they were coping. Did any doctors ever, anybody's patient has admitted in the ICU, they don't have the time for the patient, so many patients they're taking care. Did ever the doctor ask the family, while your patient is in the ICU admitted, how you are doing? Please sit down, be stable. Did anybody say? That's my good, thank you. And this is the association I did. The association between difficult to approach dying patient and ask the family how they are coping with occupation of the respondent was found statistically significant. And it's okay, go on. So conclusion, the result of this thesis, that is what I did in the master's, so health plan strategies to promote an emphasis on competent and compassionate end-of-life care among physicians and nurses of adult intensive care units. So this was just like Nazmin Appa said, quantitative research is really just a upper level of the water, like this iceberg. Iceberg, isn't it? So iceberg is 1/3 only we can see. So quantitative analysis research is only the 1/3. We need to know the 2/3 that is under the water, that is hidden. So that's why I have selected my PhD title on that basis, because I did the quantitative. Now I really want to know the real picture, what's going on, and how to improving end-of-life care in hospitals, a qualitative analysis of the healthcare providers. And I'm not only taking the healthcare providers. At that time, the master's doing, I took only the doctors and nurses. Now I'm taking the bereaved families, because I need to know not only from the doctors and nurses, but also from the families, those bereaved families, those who are in the ICU and also maybe died already. So from their story, so I'm going to do the qualitative, that means in depth, I'm going to do that. Thank you. So experiences and suggestions. So I want to know now, not the attitude, what they are doing. I want to know how this end of life care in my country that can be improved from the experience. Okay? So that's all. Thank you.